Beautiful, very good. And you can see us and hear us, right?
Yes, we can hear you well and we can see
Good.
you.
Okay, very good. So let's go our slide presentation quickly for the case number 3. So this is a 92-year-old.
Can you make sure we're across the frame? We just crossed.
92-year-old patient. Now we will show 2 cases of the tower, Redo-TAVR, you can say tau and tau. And one is the self-expanding, other one is the balloon expandable. So those are the cases simultaneously will show.
We are through the centrally, right?
By second. So this patient
That's the key.
had evolute R valve in 2016 for severe AS. So we're talking about now about 8 years, which is okay. And patient has few other things, as you can see, and develop gradual symptoms of valve degeneration, and we have been following this patient. A little bit of valvular regurgitation, but more of the valve stenosis and no PVL. Good, patient, of course, is on AFib and good medical therapy, and non-obstructive coronary artery disease. So with that note, this is the CT for first tower in 2016. So I will ask Gilbert that anything unusual at that time.
No, so you can see that here, it is a fit of 29 evolute valve appropriately, so next slide. And you can see the sinuses are pretty generous, high coronary takeoff. Next slide. This is pretty much high leaflet calcified valve, no significant, next slide. So you can see this is the initial deployment. You can see it was around 6 and 8 before release, and then I think after release went a little bit deeper. We'll show you the implant depth here afterwards. Next slide. So you can see there was really 8 years now. It was pretty good for durability.
Yeah.
That now the valve is degenerated with elevated gradient, not much PVL, and Lucy was so live about what the echo looks like.
Okay, let's show the live echo right now.
All right, here you can.
Okay.
Here you can see overall function is normal on the left side, a little bit dilated chamber. She has a very enlarged right atrium and mildly reduced right ventricular systolic function. Focusing on the TAVR valve here, you can see that the TAVR leaflets are very restricted in motion. And when we put color on, she has some mild central valvular regurgitation, but no perivalvular leak. And just focusing again on the long axis here, the restriction of the leaflets, and then we do our sweep here to confirm that there's no PVL. In terms of gradients from the transgastric windows, you can see her LVOT dimension was 2. Her stroke volume was 35. Her index stroke volume was 21. Her peak velocities are shown here with the mean gradient under anesthesia of about 16, giving you a valve area of 0.5. We did look at 3D. You can see that the anatomical non and right are restricted in motion, completely closed, with some valvular regurgitation here. And then we did our annular measurements just to confirm, and it's 430, consistent with CT.
Okay, great.
Good. Okay, go back to our presentation. So I think another point which have been coming up, actually part of the complete tower also, that annual assessment of, we can go to the presentation now, annual assessment of the gradient. And if it starts developing some stenosis, and so not the regurgitation stenosis, should we do balloon valvuloplasty and extend, compared to the surgical valve, which we don't do. So I think this is some evolving concept that once you start having some degeneration, that do a balloon valvuloplasty, or don't have to wait till it becomes severe like this particular case. So we saw that part. Now let's tell Gilbert, your expert.
Yeah, so we do for Redo-TAVR, we need to measure the nodes for a tall valve. You can see you can start from the inflow and you just measure across the frame. You can see that the valve implant was a bit deeper, so you can see that it flares outward. So when it starts to node 3 to node 6, that's when it becomes the waist of the valve, and we average around 2 to 5 because we're planning to aim for node 5 at the end. It's around 414. So next slide. So you can keep that in mind. It's about 23S3 for short valve. And you can see the green line is where we are aiming to land, but obviously, it doesn't really happen in real life because there'll be movement. but the red line represents where the coronary takeoffs are. And so, ideally, you want to have the green line below or at the level of red line, but unfortunately, this will be a challenging problem because they're flaring outward, and we don't want to have the valve migrate downward. So because of that, we're using a 23. Next slide.
And these are the two new terminologies
Yeah.
that have come up.
Yeah.
The neo-skirt plane and the
Coronary wrist plane. That's right.
These are the
Exactly.
new terminology
Next slide.
coming up. But key
Oh,
is the same. Always remember, because of the way in particularly evolute, the valve will have a tendency to go down.
Yeah.
Because
If
of
you
the-
upsize the valve. If you in this case, it'll be better. But if you just go back one slide quickly, if you can, is that you can show the top two panels are showing if you aim at node 4, you have more clearance for the coronary. You have node 5, you have less. But the problem with node 4, as I mentioned, is that you might have a sizing issue. Next slide. So you can see the commissures are actually pretty well aligned. Next slide. And this is the kind of thing that we're aiming for, at the node 5, roughly, when you can, we'll show that on fluoroscopy, which is better. Next slide. And then this is kind of where we plan to implant the SAPIEN. Next slide. And access was a bit challenging with that band, but otherwise was okay. Next slide.
So, Parashram, anything
Yeah.
about the access point of view when you got?
Yeah.
Access in the Redo-TAVR could be challenging because we're using the groin again. We chose to use the same right side as the last time because of severe angulation 90 degree at the left common iliac. And also placing the TVP was very challenging from the groin because the right atrium is the biggest chamber in this patient. So we had to use a long sheath and kind of unsheath the TVP through it.
Wow.
Yeah, patient actually have torrential TL. So this is a good discussion about bringing the patient back, maybe for tricuspid valve intervention down the road. So this is the Vinny Bapat's Redo-TAVR app. If you don't have it, you can download it for free, but just want to quickly show you what the measurements we put in from the CT. Next slide. And then you can see that it's quite complex to navigate, but once you get the numbers, next slide, what you're trying to get is where you want to end the valve. So here it shows on the red panel, if you land at node 6, no good. You're going to obstruct the coronary. Node 5 is kind of yellow. Node 4 is green, but remember, you have to size appropriately so you don't end up the valve in the ventricle. So we're going to try to aim for node 5, and we'll start probably a little bit deeper because we can see these valves to unpredictable in terms of behavior. So we have to do a very slow inflation. Dr. Keeney can talk more about that, once we are ready to deploy it.
Okay. So with that note, we are all ready for valve-in-valve. This is the basically using a SAPIEN-3 Ultra Resilia 23 millimeter in the failed 29 millimeter evolute R with the left main protection. And Anu, tell us now about what you have done so far.
So if you can go back to screen,
Yeah.
this is where we are with the pigtail angiogram. You see that, like I think Gilbert mentioned, the valve definitely is low, deeper implant. So if he goes with the node compared to if you just see where the sinuses are and how are we going to place this new valve. We were trying to see, I know he was worried about coronary obstruction, but engaging, this is the older generation valve, engaging the coronary itself was not easy. So as usually go with the J wire, this is a FL30. You see that? So we are at a higher diamond than where actually the left main takes off. But then just with the wire itself, we were able to get into the lower diamond. I think Parasuram mentioned, very tortuous left side, not even movement of any catheters are very difficult in this case. I think we are not going to leave another guide for protection of the left main. We will just go ahead with the placement of the new valve. Now crossing the Steno's tower, especially your old generation self-expanding valve is also very challenging. So you could try just using a pigtail and a J wire and see if that will prolapse, which usually does not. And then normal, we would go with the AR1, but here, because we already have the tall frame, go with a smaller catheter. So AR1 was used, so usually would be AR2, but the AR1 was used and you have a straight wire able to cross without any problem. So right now we have.
No, but let's say in this case,
No,
but what is the usual you do? Pigtail versus what?
First, we always try the pigtail with the J wire.
Yes.
Yeah, but it's rare we are able to cross that.
Okay.
But that's one thing. So you see here, it looks like it's through the diamond outside. You see that? And then the wire flops down with what we also is in this case, if you have PE, very important that you have to make sure you truly are through the lumen and not from the side of the diamond, because many times fluoroscopy, you're not able to appreciate where actually the wire has crossed. Okay.
Yeah,
It
no,
could
this-
go through the valve, through the diamond, and then get into the LV. So you have to be very clear. And what happens usually if that happens, catheters don't go into the LV. You see a lot of resistance. So when in that case, you know that you truly are not crossed through the center of the valve, then you have to recross it.
Yeah, and this is more of a challenge with the bigger cell tall valves, right? There's some out
Yes.
there that you can inadvertently cross the wrong way, and that's why we prefer TE to actually confirm that. We had a case, actually, in fact, that we show live that we crossed the outside, and there was a lot of, Dr. Kinney had a lot of resistance, and then sure enough, we were outside the frame, confirmed by echo, and then we recrossed successfully. So I think that's very important. Any comments on the panel?
And I think
Tarun?
one of the question you can have is that would you use the same self-expanding valve, knowing that lasted 8+ years on this patient, or should we go with the balloon expandable? So as you saw, our plan was balloon expandable, but will anybody use the different strategy?
So let me introduce the panel. I forgot to
Yeah.
introduce the panel. And then,
No.
so we have Dr. Anita Askar, Dr. Eberhard Grube, Dr. Renika Jain, and Yoshi with us. So Eberhard, would you like to take that question?
Yeah, I think this is, they're doing everything right. I mean, the thing is, protecting the coronary is probably a good thing. Question that comes up, do you only place the wire or do you put a stent in there just in case? The other question is protection of the brain, because there's a lot of calcium. This is an incredibly calcified valve. And as we all know, the degeneration starts at the bottom of the leaflets, moving up to the tip. So I'm not so much worried about leaflet overhang in this
We'll be ready
case.
in 10 minutes.
But I would fairly aggressively pre-dilate here, unlike I do normally. But I would do it definitely here. And when you deploy the balloon expandable, if it's clear, you cannot put it self-expanding and self-expanding.
Balloon.
So balloon expandable is also a very good decision and a right decision in my view. But when you deploy, you really have to be careful that the valve's not moving up or down. That's the danger, because the calcium is really restricting it. And if you really break it too fast, then the valve can move up, and then you have a problem with the coronaries. If it moves down, you have a problem with the ventricle. So I think it's everybody taken care of. And I mean, I know these guys know all of this, but it's an explanation of how would I do it.
So my only question was, did you consider a leaflet modification given the risk of coronary occlusion in this case? I know for Evolut it can be very hard.
Yeah, I think that's a good point. I mean, you saw that it was not that easy to engage the coronary, and often these leaflets are calcified and tall, so we did not consider that, but certainly that could be an option. But as you mentioned, that you need to do close. But having said that, there's the shortcut with just FDA approved, so maybe that's one of the device that once we have at hand that might be more amenable to do this, because it would be easier to do the double cut. At least the good thing is you saw earlier is that there's good commissure alignment.
Yeah.
Not all the time you have commissure alignment to be able to do this. So that's important to consideration as well.
Gilbert, do you
And
use
Eberhard, as you said, that we are doing a BAV. Initially, we were thinking do BAV or not, or go direct. So we are doing a BAV with a 20 millimeter true balloon. So that 21? It's a 21. It's a 21 millimeter true balloon.
They don't
Open
have
it
a
up
20.
and then put our valve. Correct. Yeah. So there was some question. Yes.
180?
Or comment.
Yeah, I was just wondering, Gilbert, do you use the TEE to look at where you're going to land the valve as well, or do you do that all based on fluoro and the nodes?
Mostly floral, because like I said, there's a lot of shadow, and you can see how the balloon behaves here. It really has a waist to it. So yeah, but we typically use floral unless we're really not sure because of all the acoustic shadow. And Lucy, you want to comment on that?
Space,
Yeah,
back up.
we could
It's
use
not for-
echo, but we have such great
80.
fluoro expertise, and you already have a valve in position. So I think they use fluoro
Very
here
helpful.
mainly for positioning.
So let's go.
Yeah, we do the
Severe.
same.
Okay, we're severe AR, so we're going to move quickly. Anesthesia team need to support us, and then I'm going to go to the frame. Well, I call it a frame alignment view. You want to minimize the number of diamonds you have to figure out what to do. So
Lucy, show some color.
yeah.
Is it more AI? Actually,
No.
Lucy is there, although one of
I don't see it.
another one
Oh, yeah.
on ECHO is the director of ECHO from my hospital, ESCC. Hemant Chaturvedi is here also, visiting us.
You have wire?
Yes, I got wire.
And it
Fluoro,
looks like AI now, or there is a low
No.
blood pressure?
No
No
AI.
AI.
No?
No.
Okay.
Actually,
Wire-related
there's a
stuff.
lot of-
It might be just the wire pinning the leaflet. It's hard to know.
Wire-related stuff. It
But,
happened.
I think it's acute severe.
yeah. But that was the good old days, with the wire pinning the leaflet, right, with the old SAPIEN. Then people wondering why the blood pressure is low is because the way the valve designed.
Yeah.
And then you pull the wire, it's fine. But obviously, we can't do that here. No.
Some wire-related stuff.
Yeah, it's wire related. Okay, good.
You brought up a
Okay.
good point about 23 versus 26 valve. Yoshi, would you have any preference in this case?
Okay.
I think they're picking the right valve with a 23.
Let's-
26
We
will
fix the
probably
mess.
be too big and will have some, under expansion, which I will be concerned about. Also, the height itself, I think that will also be a problem for the occlusion. Any tips or tricks to make sure that you're at that node 5? Sometimes even
No,
a
we
millimeter
don't aim at
changes
node
the
4.
nodes.
It's a little risky.
Not 4, yeah.
Because we have tendency, Taruna, when I was just talking in the hallway earlier, that, the valve tends to ride up, not down, because it's a 23. So 1, 2, 3, 4, we're right at no 4 right now. I don't know if people can appreciate it. So, and also I'm pulling back and it's not really responsive. So you see, it jumps up and down quite a bit. So that's the other thing. So we often use the wire. So we often like to test. So let's push the wire and see how it responds.
This is pushing the wire.
Okay, see how it responds? So that's how you kind of stand up the valve. Let's pull the wire and see.
Just pulling back.
Okay, so it drops a little bit. So that's kind of how you respond. The first operator doesn't really have a lot of wiggle room unless it really jumps up. Obviously, you have to take action. So the third operator is actually way more important than the first operator, at least in our experience. So what we don't want is the valve start to go ventricular when you deploy. And there's a very, very slow inflation. We got to test, and we actually even turn the lungs down as well. So Dr. Keeney, when she's ready, she'll make the call.
Yeah, the first and
Okay,
second
180.
operator have to really work together
Lungs down.
in order to give them the chance to move the valve.
Cine, try Cine. So it's high, right? Okay, so it's high. You see that?
Lungs back.
Okay, lungs back on.
Going.
So I'm gonna go in there.
Yeah, good.
So see,
Stay
but
there.
yeah, see.
Yeah, going,
Okay.
going. You came back
Yeah.
up again.
Yeah, great. This is 4.
Going,
Okay,
going.
so I have to go. Yeah, this is 4. This is low 4.
Good. Okay, 180.
Lungs down. Very slow.
Going.
Okay, see how it.
Advance.
Okay.
Advance.
Yeah.
Pulling the wire back.
Yeah.
Advance.
Yeah. I can't do too much. Remember.
Pulling the wire back.
Yeah. Good. Yeah, all the way. Yes. Good. Perfect. So you see that, it's a very slow motion. Keep pacing.
So
Okay,
Gilbert,
I'll-
is that a 23
We'll double
nominal
tap.
that you put in, or are you going to go
No,
back?
actually, good point. Lungs back on. It was +1.
Okay.
So because we know that there'll be recoil issue, in fact, we're going to add 1 cc now. We could do an aortogram
One
quick
more
just to
cc,
make
yeah.
sure we have no
You
issue.
need wire.
One more CC.
Yeah, that's
There's
the.
no issue, then
Get the
we'll
wire.
go once again.
Not this.
1 cc added.
Okay, actually.
I think that
Just to a
Now,
quick
Gilbert, you said about the lungs down. What is the importance of the lungs?
Well, any respiratory motion can also make the movement.
Yeah.
Especially patient with COPD or big obese patients. So that's why in our mind, I know people want to do minimalistic Redo-TAVR. We're still learning. And I don't want someone to take a deep breath and under MAC and then the whole thing moves. So we learned that, especially in aortic procedures, endovascular like a TAVR. So that's why we think that anything we can minimize movement, it's appropriate for the patient. So we're going to do an aortogram now just to make sure the left main's still okay before we choose to post-dilate. And people say, why are you post-dilating? We've seen now, we've actually done some CT analysis that show that this valve is not going to be 23 when you do a CT. It's going to be smaller. And so we want to expand this valve as much as possible. We know that she's 92, there's a stroke risk, but we don't want this valve to fail because then she won't really have not much option to think of. So. What do the panels think? Any comments about how to do this? Because we're all still learning. There's no one way to do this. This is kind of how we've done it. We've done almost over 40 Redo-TAVR now this year, out of 510 total TAVR. So it's not 0.5% as we've seen in the registry. It's actually almost 10% now. And because patients, first get the low-risk approval in 2019, and they have SAPIEN-3 and they have Evolute, now they're coming back over 5 to 8 years, depending on the life expectancy. What does the panel's experience in terms of their, how many cases are they seeing? Are they seeing more or about the same compared to previous years?
At Cedars-Sinai, it's around 1 case a week. That's what it's been. Because you're absolutely
Wow.
right. They're now coming back. We did these patients, but we also did 600 TAVRs 8 years ago. So there was a lot of TAVRs. And there's referrals from community that are also being referred, especially the self-expanding valves. So the volume is increasing dramatically.
Nice. Okay.
Note 4.
All right, good. So you can see the aortogram, we're definitely far away from the left vein. So we actually ended up just at no 4, which is good. So we're going to post-dilate now.
Good.
And you can see we added actually 1 more cc. So what's your wire, please?
Yeah. Good.
Okay.
Okay, 180 again. It's LV.
Okay, back.
Yeah.
Do the hemodynamics.
Okay,
Picture
yeah.
ready?
Off, back
Off,
up.
off.
Lungs back on. Okay, now we'll exchange for a pigtail. So you can see this valve actually cut in between the inflow to no 4.
Yeah.
We would have done 26, that would be a big problem. So we rather go 23 because, that's the inner leaflet portion that takes up 1 millimeter thickness. People actually on CT scan, you cannot see that. So actually the inner diameter, if you think about the Vinny's app, the top in SAF app, that there's this true ID. So I think about the true ID as actually including the leaflet thickness. And these are diseased leaflets, so you actually subtract that further. So I think in reality, even though the frame itself might measure suggesting on 26, 23 may be more appropriate because we had a live case. Actually, we did a 34 Evolute with 29, and actually really went into that deep, and we had to rescue a 26 Sapien.
Yeah.
Dr. Sharma?
Yeah, so no, that's always, so I know that you did say in this case that there is a tendency for the valve to come up. I thought always was the tendency to valve to go down.
Depends on the sizing.
Okay.
So if it's a 23 and a 29 Evolute or 26, it will go up.
Okay.
But if it's a 26 Sapien, it will definitely go down.
Yeah. So just want to say that have to be careful on that point. And as you saw that multiple steps were done, that where it's going to move and go slow. So if it is, then you have a time to readjust.
Yeah.
So you don't have to do all or none, what we do usually in a.
So let's look at hemo and Lucy look at echo.
You saw it was moving up.
Yeah, that's right.
I mean, that's why we were trying to push it. At some stage, it got stuck.
Yeah.
And then we just.
And the wire. So Lucy, let's show us the echo, please.
Sure.
And then we'll do hemo.
0.
So I'm just tracing out the gradient now. There was no evidence of PVL. The mean gradient is 2.
Wow.
And I can go ahead and show you some of the assessment by color here. So here you can see short axis and long axis, multiple sweeps, no PVL. The leaflets look thin, they're freely mobile, no issues. This is a very nice looking valve.
So did you see any of the leaflet overhang that people were worried about? Because there's a recent paper that showed that actually the leaflet overhang is not as bad as it was on explanted TAVR and did a bench study from Stephanie Seller's group in Vancouver. That, as long as you let it know 4, you will be able, you're not going to have this draping effect. Did you see any of that evidence here?
Yeah, I don't see any leaflet overhang. I would see it here on the long axis view, and I really don't see anything.
Good. Okay.
And look at the hemodynamics.
Yeah.
Wow. And we are going to be ready. That's right.
Okay, any questions?
Any questions on the panel, audience? We have
Yeah,
another
can I just
tap for you,
question,
so we're gonna
this
go right
leaflet
there.
overhang thing? I'm not sure what I mean, we know what it is, and I'm not sure. First of all, here, I don't think there's any danger of leaflet overhang for many reasons. But, do you really believe that leaflet overhang has something to do with durability or, improving devices here in a 92-year-old?
All right, let's go.
Even if you had it, more important is the inflow, not so much the outflow, I think.
Agree.
I think there are. So we've
We are
seen
ready
leaflet overhang,
in room 1.
but it has not been as big of an issue as we worried about. But yeah, I mean, theoretically, when there's leaflet overhang and this thing is flickering, theoretically it could break off and cause embolic complications in future. We haven't seen those, But also we haven't followed these post Redo-TAVR patients for long enough to really know.
Yeah, although I will say from the echo perspective, I'm with you. Like, I used to really worry about it a lot, and you see it on the echo, it looks awful right on the TE. But in following these patients out, I don't think we do about 500 TAVRs a year. We don't have one TAV failure a week, but we have a fair number now over the last couple of years, and it doesn't seem to be as much of an issue, and I think it's a really good point in a 92-year-old that you're not necessarily worried about 8-year, 9-year durability, so.
I mean, I'd be worried about the flow inside, in between the leaflet, the existing leaflet and the new leaflet. If the flow is not dynamic, sometimes it can cause stasis, leaflet thrombosis, et cetera. I don't think we're going to see that immediately. But if the valve's degenerated, I would think that the leaflet will open up and stay that way and not really overhang. Just like, we've all seen the films that that Jannar has sent out to everyone.
No, I'm not questioning. My point is, if you you have to make a decision. When you do a balloon expandable valve, you have to make a decision between inflow and outflow. What's more important, the outflow? Are you going higher to prevent leaflet overhang and then let the inflow not expand enough? Or do you concentrate on the inflow even at the risk of a little bit of an overhang? That's really my point.